Hello, everyone. I'm glad to be here, and that was a great introduction, and it covers my introduction slide.
With graphics.
Yeah, with graphics, so you now you can see the logos and all of that. So today I'm going to talk about my program of research, and so it has two arms, if you will. So the first arm is how the nurse work environment as a hospital structure influences how nurses work together, the processes, and how that influences the outcomes. And then the second major focus of my research is looking at the organization of nursing within rural hospitals and how that affects patient outcomes. And I'm going to explain why nursing, because a lot of you in the room might be from kinesiology or from other disciplines, and I want to explain the importance of nursing at the bedside and how it relates to my research. So nursing is the front line of the health system in virtually every setting. So in the clinical environment, the nurses at the bedside are the boots on the ground. They're the ones who are assessing the patient. They see what's going on in the work environment, and they're able to identify problems and catch them and make an intervention and do something about it. And so when we study the work environment, we survey nurses so that we can get their perception as expert informants about what is the work environment like. And I'll explain all of what a work environment is in the upcoming slides. But before I do that, I just want to give you a bird's eye view of kind of where I come from conceptually. So just for my knowledge, how many of you have heard of Donabedian's structures, process, outcomes? Anybody? All right. So for those of you who haven't, just to briefly explain it, Avedis Donabedian was a physician, and in 1966 he developed this conceptual model about how the way a hospital is structured, its organization affects how things are diagnosed and care is delivered. That's a process, and then outcomes is what happens, with the patient, and based on the linear process of structures and outcomes, so that without a structure, you can't achieve the outcomes that you are looking at. And so with nursing, I took this and I used, instead of having a physician model, I looked at how the nursing work environment and collective efficacy, which I'll explain, is the ability of a nurse work group to come together and accomplish a goal, which is to take care of the patients on the unit. So that's how that it's structured. And then the process, I look at two different things. I look at how the work environment, how people function as a group. Are they dysfunctional or are they functional? So are they civil or are they not? And then are they able to come together as a group to accomplish the care needed for the patient? And the outcomes, I have them in italics because I wasn't able to look at the patient outcome in my dissertation due to constraints of data collection, but I want to see how these factors influence actual outcomes, especially in the rural setting, such as patient mortality for certain things that are especially concerning in the rural environment, like heart failure and stroke, and some of the more common things that occur. And so just to give you a little view about what the quality health outcomes model is, so this takes Donabedian and kind of blows it up a little bit, so that everything is in the system. See that top bubble says system? So there's four major parts to this model. There's the system, which is connected to the interventions and the outcome, and eventually the client or community. So one thing, if you don't take anything away from this slide, take away that everything is dependent upon the system. You have to have good structures in place to achieve the outcomes that you're looking for. And so everything that I study right now is within the bubble, lives within the systems bubble. But I want to expand out and look more at how it affects communities. And so what is a nurse work environment? You probably heard me saying this and wonder, what is this exactly? So this is a sort of a sociological construct, and if you were to look it up in the literature, it's basically factors about an organization that either facilitate or constrain nursing practice And by that, I'm talking a little bit about autonomy as well. And so there's 5 domains that the nurse practice environment scale the PES and WI measures. And that's how we measure the work environment. And it's nurse manager ability, leadership, and support of the bedside nurses, staffing and resource adequacy, which includes not only staffing, but whether the hospital is equipped and have the supplies that you need. Nurse involvement in hospital affairs. So are there evidence-based practice groups and councils? Are there things that nurses can join? Do they have a say in the organization? Nurse-physician collegial relations, nursing foundation quality of care. So all of those domains come together to make the PES and WI, and it's a 31-item questionnaire. It's been validated. And so this is my, this is the first publication for my dissertation. It was accepted October 5th, and I submitted to the Journal of Nursing Management. And this one, because I covered so many different things in my dissertation, when I went to Penn, I worked on packaging it down into manuscripts and to make the most impact and convey each topic. So this was the Association of the Nurse Work Environment with Nurse Incivility in Hospitals. You don't have to read all this. I'm going to point out these salient points about this research study in the upcoming slides. Nurse incivility is, if you were to look at the way it's defined, it's the occurrence of low-intensity behaviors exhibiting an ambiguous intent to harm. And so what that means is it's not overt, it's not direct, such as you might have heard of different terms. You might have heard of workplace bullying, you might have heard of horizontal violence, you might have heard of lateral violence. There's all these different terms in nursing to talk about mistreatment in the workplace. But incivility is particularly captured my interest because it's at a lower level, and if you catch it at a lower level in an organization, it doesn't permeate the culture and you're able to contain it and keep better norms. But it's all based on the idea of what is a social norm. And so if you're violating a social norm in a very minor way, that's what incivility is. So if you think about it in terms of what it really looks like, it might look like gossiping or spreading rumors. It might kind of look like something that you really can't tell what the intention is, but that it's disrupting the workplace. So there's a lot of literature that has come out of, for example, Australia about workplace bullying, and they've found that some of the antecedents or what precedes it, not directly causing it because we can't really prove a cause and effect, but the way the organization is structured, whether there's a lot of hierarchical levels, if it's more flat, there's a little bit more communication occurring. So there's those sorts of things. There's culture and politics within the organization. And so you might want to know why it's important. And it's really important because of nurse turnover. We don't want that to happen. It costs a lot to train a nurse, it costs a lot to keep nurses, and well-trained nurses are part of the workforce. They're part of what delivers great outcomes. So there are 2 main organizations that I want to point out that have discussed incivility in some form or another. And the first one is from 2008, and that's the Joint Commission. And they said broadly that disruptive behaviors are linked to medical errors, and they have a Sentinel alert talking about that. And in 2015, the American Nurses Association issued out a position statement specifically about workplace incivility and bullying and what it is. They define it, and then they talk about what can be done and how it's everyone in the work environment's responsibility to address it, and kind of the ethical piece, because they also have a position statement, separate one about ethics, but that's typically. And what I find striking is when I look in the literature, and this is in 2016, it's still going on. And if you look at the title, addressing the elephant in the room, if you think it's almost like they're saying it's you think, but I mean, it's going on. And what I find significant about this study is that over 80%, 86% of the nurses, they say, yes, we are seeing it, but yet there isn't as much of an intervention until it's more overt. And that was a study specific with leadership and management. So the survey was just all about that. And so I think that it's still a problem. And with my particular study, I'm going to talk a little bit about the methods of my study. So I looked at this in a cross-sectional correlational way, meaning that I collected survey data from nurses over one time point. Over the last month, I asked them about their work environment, asked them about the instability. And for the work environment, the questions have a Likert type scale response. So you could say that you either 1 strongly disagree or 4 strongly agree. Instability, it's more of a frequency scale. So 0 never happens, 6 daily it happens. And the nurse sample that I was able to obtain, I had 233 nurses, and it was across 5 different hospitals in the same health system. And I got more critical care, medical, surgical than any other specialty. And because it was such a large system, they have specialties like transplant. So I did get, a number, of transplant that I wouldn't normally. But for nurse education, I found it significant that at least in my sample, there were almost 3/4 of BSN prepared nurses, and they were less experienced than your average, than the national average. It's less than 1 to 2 years experience, around 40%. So it was, if I could characterize it, I would say it was a younger, well-prepared sample that I obtained. And for incivility, I have here a histogram, and what this is telling us is the average was sporadic. If you translated the mean, 0.58, closest to 1, which on the survey 1 is sporadic. So that most people sporadically experienced it on average. However, it's really hard to see, but there's some at 4 and 5. So you have these outliers where the majority are reporting it as much, but there are some outlying, and I wonder if that's more on the bullying side. I don't know the intensity level of that. But one thing that I thought was significant, if I can talk a little bit about the items, was the highest scoring item was pay little attention to your statement or show little interest in your opinion, which I find troubling because everything we do, a lot of what we do in nursing is communication based. And if you can't communicate and feel like you're being heard, and you've been the nurse working there for 12 hours with the patient, it's a problem that needs to be addressed. And the lowest scoring thing was addressed you in unprofessional terms, either publicly or privately. And I think that begins to become a little bit more overt of a behavior. For the work environment, I found that on average, they rated their characteristics as it was a favorable work environment to be in. And one thing to know about the sample is that I collected my data among magnet hospitals or hospitals that had pathway to designation. And for those of you who aren't as familiar with that, that is a program that focuses specifically on nursing excellence. So take that in mind as a caveat when looking at the results, that there could also be an association with that. But because I didn't specifically have them respond, which hospital, I wasn't able to look at that, so I wasn't able to correlate that, which I had to address that in the review recording. But in general, the more positive the work environment, it was correlated with lower scores of incivility. And the domain that was most correlated with it was nurse managerability, leadership, and support of nurses. Here's a scatter plot. And so each of these dots represents a nurse respondent, and where they fell on the graph depends on what their answer was for work environment and what their answer was for incivility. So if they're closer to the right part of the screen and they're lower, that means that the work environment was better and that the incivility was less. So as you can see, there's a slight negative correlation between work environment and incivility, so that they're related in that way. The implications are that nurse managers they're pivotal in addressing workplace incivility, and that they should ensure adequate staffing. And for future studies, I think it would be a good idea if we do these interventions to look before, measure it before, do the intervention, measure it after, and at multiple time points. So my next paper is not focusing on incivility. This one is focused on the work environment and collective efficacy on missed nursing care. So I submitted this paper to Western Journal of Nursing Research, and it was accepted, and it came out like a week after the other one did, and someone came to my office and said, "Oh, are you at one a week now?" And I said, "No, not quite." It's just kind of a coincidence. Anyway, that was kind of funny. So collective efficacy is the confidence that a group of nurses can accomplish a goal. And so this is kind of at the group level. So I'm sure that many of you have heard of self-efficacy, which is the ability of an individual to accomplish a goal. So collective is taking all of those people's ideas at a group level. And so here's the way I envision it. So let's say you have a shift that you're going to work on. You look at who's working with you, and you automatically feel better because you know the people you're working with are very competent, and you feel like it's going to be good no matter what. So that's what I envision collective efficacy as. Missed nursing care is, if you were to define it, it would be an aspect of any aspect of patient care that you leave undone, if you omit, or is significantly delayed. You know, medications that are significantly delayed for whatever reason. Now, you might see this in the literature as unfinished care. You might see it as rationed care. There's different terms, but it all comes back to that point of it wasn't done and it should have been done, and regardless of whatever reason it was. So in this study, first going to describe each of the independent variables, their descriptions. So for collective efficacy, I found that they mainly had a higher on average score. So it was 4.95 out of a possible 6, which made sense to me if they had a lower incivility in the sample, but it wasn't part of the study. But to me, it was kind of making sense. Their answers were consistent. And some of the items on the collective efficacy belief scale are worded in reverse. So you might see where it says this department is not able to perform as well as it should. And so they'll answer these questions. And what I did was I reverse coded them so that when I put them all together, I could get something sensible to analyze, if that makes sense.
What was the score of the inventory? Like, is it 1 through 10 or?
It's like 1 through 6.
Okay.
So it being 4.95, it was a better favorable score. So this is kind of a detailed slide, just to point out the salient pieces. So I measured nursing. When I did my analysis, I looked at missed nursing care, missed frequently to always. And so here's how I did that. So missed nursing care was measured by a 21-item scale by Beatrice Kayla. It's called Missed Care Survey, and it is a self-report thing. So the nurse reports about their experience or perception of missing care over the last month or shift. And so it's like it's like a frequency scale. It's like 1, rarely, and then it goes all the way up to frequently to always. And so I took 3 and 4, or frequently and always, and I calculated the prevalence across my sample for like what items that were they missing frequently and always, because it's not been done in the literature, but I thought it was important to know what is being most missed. And so keeping in mind that the sample was dealing with medical surgical patients and critical care patients, I found it significant that mouth care and things like turning, so mouth care 36% missed frequently or always, meaning it doesn't have to be like they always miss it, but they might just say this is a thing that gets frequently missed. And if you're doing that like every 2 hours as an ICU nurse, you might miss it just one time. But if you're really reporting in the survey what's going on, you'll see that, I mean, that's part of how the prevalence occurs. But so the least missed things, bedside glucose monitoring, hand washing, patient assessments, things like that. So for the correlation of the work environment and efficacy in miscare, here's a table that shows all the correlations. So the mean column is what the average of the scale was. So the PES-NWI composite is all of the other scales except for, it's all the 5 scales put together. So on every dimension, the work environment was correlated positively with efficacy, meaning that better work environment was correlated with improved ability for the group to work as a team and function and believe they can accomplish a task, which made sense. And with miscare, not every scale or not everything was correlated significantly on all domains, but there was a weak negative correlation for how the work environment compares to miscare. And here is a scatter plot of how the work environment looks with efficacy. So the other one you saw the line going down, this one you see the line going up because it's positively correlated. And just to briefly explain, this path analysis model is, I wanted to know how collective efficacy in the work environment simultaneously could be, not predict, but are associated with miscare. And so this model had a significant fit. As you can see, the work environment efficacy were correlated as we already saw in the other thing, but it was correlated again in this model. And there was a correlation, albeit a smaller one. However, when I look at this with the limitations of my study and how it's theoretically applicable, I think there needs to be future studies about that to confirm, especially at the group level, aggregating all of this like at the hospital level and comparing. But I do think that the work environment and efficacy based on these findings does have something to do with miscare. It's not going to explain all the variants, but there's a connection that I think deserves further exploration. So this next paper, this is a project that I worked on with my mentor, Dr. Eileen Lake at University of Pennsylvania. And for this study, we looked at how nursing care disparities in neonatal intensive care units were correlated. So we looked at missed nursing care and how it varied across hospitals based on the percentage of black infants in those hospitals. So there was like low, mid, high. And we found that in hospitals with the higher percentage of black infants, there was more miscare, meaning we need more nurse staffing resources in these hospitals, because this is really an area that the miscare thing is growing. I mean, in 2006, there started to be kind of an uptick in the number of studies about miscare, but there's not a lot about individual populations, which is another kind of area that and then this paper is one that I recently got accepted in Journal of Perinatal and Neonatal Nursing, and this is a little different, but what it's looking at is infant drug withdrawal across the United States using a secondary data set, comparing infants in drug withdrawal to infants not in drug withdrawal on these metrics, on how nurses are staffed to those infants, what the parental needs are for those infants, whether they're complex needs or not, and then so you can see here in these pie charts, you can see that the one on the left, if you can't say, I'll just kind of say, so there's 166 infants that had drug withdrawal and had parents with complex needs, and that was 20%. So 20% of the infants of the 361 that were actually in drug withdrawal had complex parental needs. Compare that to the general other population, other sample half that I had, which only had 6%, the nurses said 6% of those infants had parents with complex needs. So there's a magnitude difference in that, in their needs. And this particular histogram, the journal didn't want it, they said it was redundant, but I included it because I think in this presentation, I think it informs. So there were 104 hospitals in the data set with around 6,045 nurse respondents and then 15,233 infants. So what this is saying is there was 27 hospitals that had no reports of infants in drug withdrawal. And then it goes on from there, and you can see that there was like one hospital that had 22, there were some outlying ones, but it wasn't an evenly distributed, but that in some areas there was more problem. But to depict what it looks like across the country, we put it on this map where you can see we didn't have data for a lot of the states in the West, so we can't really say exactly for those. But for the blue dots, that means at least one infant was in drug withdrawal in those hospitals as reported by the nurse. And the yellow ones were no infants in drug withdrawal. And so this is just to kind of give you a distribution of what it looks like across the country. And so before I go on, I'll just say, so this is a growing topic with the opioid epidemic. You might have heard about all this and that. So this article is supposed to be published in a special issue about nursing ethics and legal in that particular journal. So be on the lookout for that. Okay, so, and then this is a study about misnursing care across the U.S., looking from a different angle, a little bit different. So this is a paper that has recently been submitted that I've been analyzing, I think since like January. It's been just a continual process because we'll analyze it, we'll get together as a group and we'll talk about it, and then we'll say, wait a minute, what about this or that? And so it's a real process to go through the analytics. But what's different about this paper is that we're looking at how patient load that is adjusted for the acuity of the patient might impact miscare. So we already know that there's literature about how the work environment affects miscare, but we don't know so much about how the nurse's individual load, adding on the fact that they might have really sick patients, adding on the work environment, so that if you have a hierarchical model, if you have all these things stacked up, how do they predict miscare? And so that's kind of what the paper adds. So that's under review right now. So, and it's so the second arm, if we could kind of shift gears a little bit here, and talk about rural a little bit. So I'm really interested in the rural work environment for a few reasons. I did grow up in a rural area, and I'm from Texas, but I worked in a rural hospital for about 4 months. It was in Bowie, and it was at the time that I was already like deep into the dissertation process, but I came back from Wisconsin to Texas to live with my parents and kind of that sort of thing. And so I wanted to get more clinical experience, so I thought, okay, I want to work at this hospital one. And I got to work there, and for the short time I worked there, I learned a lot about the culture environment that intrigued me. And though the hospital closed due to financial constraints and disagreements about how to fund it, I still had questions about, how does this differ, and what about these patients? What kind of care are they going to get, and what were they getting? And so when I went to Pennsylvania, I was encouraged strongly to publish my dissertation. They told me to do that. So I worked on that, but I was also told, well, you be thinking about what else you want to do and how you're going to extend this. And I thought, well, why not look at that? And so I applied for some small grant funding from the ANF and TNF, and they support that. So I'm currently looking at how rural and urban differ, just to set it up, and hopefully that can be a descriptive type of paper. That's what I'm working on right now. And then I eventually want to look at how the rural organization of nursing affects the outcomes of the patient. So like I said, what is the organization, the work environment, patient to nurse ratio? We're looking at RN skill mix, or what the skill mix looks like of all the nurses. So looking at RNs and LPNs and averaging that as a denominator and having, so that sort of thing. And then the level of education of the nurse. So looking at all those factors and whether or not they make a difference in the outcome of the patient. And so I've told you a little bit about why rural nursing. And from an objective point of view, there are 1 in 5 residents in the United States that live in these rural remote areas. And they're often older and have chronic illnesses. I know personally, my parents, they've lived in a rural area their entire life, and there's no indication that they want to move from there. So I know that they get attached to where they live, and it's part of their culture, it's part of their beliefs. It's just the church and all these, their community is just close, and it's sad to see these hospitals leave. So I guess going forward, I'm thinking, how else can nursing serve this? But that's another futuristic thing. So I've told you a little bit about my current research, and so if you look at the aims that I proposed, I'm looking at all of these nursing things in 4 state data that Dr. Linda Aiken has collected in 2015 for some of her other research. So it's in Pennsylvania, Florida, California, and New Jersey. And I'll just tell you right now that there are no rural hospitals in New Jersey that...
You can substitute Texas in there.
Yeah, so this is what I'd like to do is I would like to extend this and collect data in Texas, and so I could compare and serve this particular area. And then also, other than looking at the objective, they're looking at the patient data, such as the patient mortality rates. I wanted to look at nurse-reported outcomes, because in Linda's data, she has different things like, how would you report the work environment, safety grade, and infections or nosocomial. There's all these different metrics, so I was going to look at how some of those compare between rural and urban. And so, like I said, I really want to continue looking at this, and maybe even if I was able to look at different time points, say how I know that there's data that exists from 2006 from their last big data collection. I was wanting to see if there were differences between the time periods and how that differed, and maybe in the future how that differed. And I don't want to let go of the incivility and collective efficacy thing, because I feel like I'm being pulled a little bit because of my interest, but I still have those interests about making the process in the work environment better. So I want to try to keep them both going. So one of the things that I'm really trying to do with that is I'm trying to focus on federal funding opportunities, maybe NIH or AHRQ. And also I wanted to point out some of Deborah Behan's work is relevant to what I'm doing, and it relates to looking at how evidence-based practices are applied depending on magnet status. So, and a lot of the research that has been done on magnets is kind of relevant to the work environment. They go together. Not the same thing, but it's a proxy to measure the quality of the hospital itself from a nursing standpoint. So I appreciate everyone listening to me and being here. And if you have any questions, feel free to ask. I went through some things quicker than others. So I just think it's important on many different aspects to pay attention to the work environment and its effects. I mean, clinically, on a policy level even, research, theory, practice, it all comes together. So, like I said, if you have any questions, you can email me or ask. So
let's spend some time with Q&A now.
Yeah.
Okay.
I have a question. I thank you very much. You did a wonderful job. The question about interventions. what kind of an intervention would you think would make a difference in workplace so that it would improve some of the PSQ scores, the ones that you identified? What, on the part of a hospital administrator or nursing leader?
Right. I was thinking maybe training interventions for leadership and management to help them identify and feel comfortable addressing problem, things like incivility, and maybe even teaching staff, there's cognitive rehearsal is in the literature about ways to respond and ways to kind of shut down, behavior that's going on. So I think that you could do an intervention that was targeted specifically at leadership, or you could do one broadly. And I think maybe targeting would be a good first way to look at it.
To ask my colleagues who teach in undergraduate, is this kind of content covered in our undergraduate curriculum?
I think it is to an extent, but I think it can be, as it's becoming more and more prevalent, we need more education at like that season 2 level.
I was talking with Jessica yesterday, we see this in our students. We see the incivility piece, and so we try to address that as we can, really addressing it in management, which is their senior 2 level, but also knowing that they're witnessing this in the hospital environments. Mm-hmm. And so if we don't get, I think, more education to them in the undergraduate before they get into that working environment, they're going to think that's okay. And we know it's not with
examples of this. They see it in their clinical experience.
And I think we can do a better job of debriefing at our clinical experiences to role play, if you will, some of the responses and taking that personal accountability to say something, but to say it in a very professional way.
Right.
We need stimulation.
Simulation. You got that? Simulation.
We designed to
I
study
had a
last night at
feeling you
dinner.
did.
Yeah, we did.
That's not surprised me.
But also, I think it starts with the students themselves.
Yeah.
There's a lot of instability in the students.
And bringing that awareness to them that this is not okay.
So maybe a good intervention is you might consider, I know you're focused on the workplace and that's a good place, but maybe before the cow gets out of the barn, we need to do something
Right,
with the
yeah.
students rather than.
We can expand your work, I guess.
Yes.
that's what
Right,
I'm saying.
yeah.
Yeah.
It's out of the barn.
Yeah.
How in most organizations, it's the top management that is a major barrier. They have, for example, in hospitals, they have for beds, they have to basically make money for the shareholders and whatnot. So, how can you impact on hospital administrators to provide more passionate training?
I'd say the literature that talks about the turnover and how expensive it is to train one nurse, $90,000 or something like.
That's the latest figure,
Yeah, so it's significant for the organization in that regard. I guess if they spend a lot of money training nurses, and then the turnover, and then they train all over again. So I think that would be one point to bring up.
Have you seen any benefit to interprofessional education impacting the workplace? I know that's becoming much more used now.
Right.
And certainly physician disruptive behavior is certainly not being tolerated in Texas hospitals. And that should also correlate with nursing disruptive behavior.
Yeah, that's a very good point. And there's some interdisciplinary literature. I know in the collective efficacy, building that sense of work group effectiveness and how it relates to better outcomes. I would think that was a simulation, postpartum hemorrhage or something, but it was still along the same lines.
Thank you for your presentations. Wonderful. On your missed nursing care, And did you consider or take into consideration in your numbers the RN's ability to delegate to the unassisted licensed personnel like the CNA and the respiratory therapist to clean, like the mouth cleaning, the mouth care, and for the maybe for the finger sticks, glucose monitoring?
Yeah, it's a very good question. So in the question stem, it does account for tasks that you delegated as well. However, in some studies, they actually administer the survey to unlicensed assisted personnel, different types of licensed nurses. In my study, I just looked at it from the RN perspective, but that's a good point. It's a good thing to include in the study how you want to survey to get the data you need.
No other questions? Are you sure? Okay.